Yeah.
You guys hear me?
Yeah. I think they. So that's where that message came
Hear me out there voting New Orleans? 1, 2.
We sent it to our code and
Testing.
so I did set up, but I, during it, sure. Last year we did 3 Fridays. Provide get, and trying to get to 2 Fridays and not around. Makes it a little bit.
About 6 more minutes till we get going here.
Thank you. Everybody here and elsewhere, all the places that can hope you hear me right now. So, today we're about benign breast disease, which really is a huge topic, and there's so many things potentially that we could cover in that. I selected a subset of topics that I see regularly and I think will relate to you guys as well. Absolutely free to ask questions as I go along, and I understand that case-based format works well for you, which is great, because I was able to take cases that I have seen in recent months and show I can kind of go through what happens after they've come my way and the final outcome. Let's see, make sure I go direction. Okay, so talk about a couple cases in breast pain, nipple discharge, infection, and the palpable breast mass. Starting with breast pain, which is a super common complaint. I'm sure you hear about it a lot, and I certainly hear about it either as the chief complaint or in the spectrum of all the symptoms that they're having in their breast when they come to see me. Well, it's a generally benign condition, self-limiting. There's a whole bunch of different presentations for it. Some people have cyclic breast pain, with cycle very consistently. Many women, though, even if they're still premenopausal, have a seemingly random breast pain. It kind of comes and goes, no particular pattern to it. And that is also very common. People at the off-site can't see that, but it's just waving at somebody. It's very rare as the initial presenting symptom of breast cancer, which is always very reassuring for patients to hear, because in general, if there's anything that seems the littlest bit abnormal at breast, the patient, it's often breast cancer until proven otherwise. So breast pain is a really unusual way for breast cancer to present. Can never say never. It does happen, but it's not. Lots of different things potentially can affect how the breasts feel and breast tissue sensitivity. Mostly we think it's generally hormonally related. It can be affected, though, by caffeine and changes in weight, different medications, and even just anatomy, very pendulous breasts. You mentioned then in some parts of the breast more than others, and that can be a little bit. So I think, let's see, did I cover most of this already? Just in talking. So we talked about being cyclic or intermittent, characteristics that are very reassuring. If it's bilateral, diffuse, not a specific location. When I'm talking to patients, I usually say pain that would be concerning to me that we'd want to investigate further would be pain at a very specific location that you could say, put your finger on, and it's come on, hasn't gone away, and it just keeps getting worse. Because we're thinking about what things we're worried about and want to rule out in the breast cancer, first and foremost, and it doesn't just go away on its own. So if you have pain cancer, it's not going anywhere. It's just remain present and keep getting worse. If there are any overlying skin changes, we want to know about that. There's also a lot of things that can present with a complaint of breast pain, but may not be related to the breast at all. Musculoskeletal pains, you pull a muscle or have a little costochondritis, that can frequently be perceived as breast pain to the patient. So it's a little bit of figuring the course of history and physical, and then imaging to rule out anything concerning. So in this case, patient she's in her 30s, viral breast pain, and it seems to correlate generally with her menstrual cycle, pretty consistent. Reports that her breasts have always been, quote, lumpy. She gets ultrasounds, and it just shows small bilateral, benign appearing cysts of malignancy. A very common story, really. You can have what we then call cyclic mastectomy, pain with the cycle, related to fibrocystic breast change. Oh, that came across a little differently. And I just include this because so many women report their breasts as lumpy, and area variance is normal. Fibrocystic breast change used to be called fibrocystic breast disease, and it's been changed over time because it's not a disease at all. It's really just on the spectrum of normal. And so assurance to the patient, but also understanding that, yes, it is difficult for them to do their self-exams because they have quite nodular or lumpy feeling breasts. And letting them know that if they feel a new mass that they really think is new, don't dismiss it and just say that it's your fibrocystic breast disease. Yeah, still get it checked out. Strategies that you can give if somebody comes in with a history that overall just sounds like benign breast disease, or benign breast pain, and you're not concerned for anything further, or you've done imaging which looks completely benign. They can read sources of caffeine intake, and that's a very risk-benefit kind of assessment. Many women, if you hear, oh, you could cut out all caffeine. That means all chocolate, all coffee, all stuff, all set. I'll deal with the breast pain. It's not that bad, and that's fine. It's really their decision. If it bothers them enough that they want to make a change, go for it. Otherwise, it's not dangerous. You don't have to. Cutting back on salty, fatty foods, definitely wearing a supportive bra, even going for a professional bra fitting. Women are in the wrong size bra and really not being well supported. Then help. Sometimes high-dose omega-3 fatty acids. The multivitamins, you can take that, or you can even take a supplement called Prevail. Some recommend that for patients that have significant pain. That said, any one of these can take a couple months to have an effect, other than, say, taking NSAIDs for acute episodes of pain. And pain may go away on its own during that time because it tends to be self-limiting. Can sometimes. Yeah. And everybody's a little bit different. So one strategy will work universally for all patients. So it just depends on how much it's bothering them and how much time and energy they want to invest in trying something to make it better. If the pain is so severe that they've tried these strategies, or as many as they're willing to, and still not getting better, there are additional steps that can be taken. It's very rare that we really get to this point. Most people, reassurance and maybe some of the lifestyle interventions that we talked about will be enough, and then they're kind of over it and will just decide to deal with it. Hormonal influences, maybe changing or stopping, oral contraceptives, again, different for everybody. The guarantee of, changing to something else will definitely make a difference, so you have to decide how much is worth to you. There are hormone-suppressing medications, tamoxifen, for example. These all have side effects. Again, your breast pain has to be pretty significant to actually make that worthwhile. And then really, if these all fail, surgery. But if I'm giving patients instructions for what to try for their breast pain, and I've met them for the first time or even the second time for their breast pain, I've been putting these last two categories in their instructions to think about medicines for this that have potentially significant side effects. Surgery, I don't really want to put the idea in their head that surgery can be a miracle cure for breast pain. Not in the business of removing breasts for breast pain. So that would be an unusual situation. Okay. 20-year-old female came in with a painful mass in her left breast. She'd actually had a lump in this breast for many, many years, since age 13. I guess she's 26, it's only 13 years. And had some pain at that site for a long time, but recently it's gotten bad enough that she actually wants to do something about it. She comes in, she has tenderness at that site, just above her areola on the left breast. It's not a defined mass, to get an ultrasound. She's actually found in the area of tenderness to have a 4-centimeter cyst here in this bottom corner. So it has a thin wall, just filled, but simple cysts do not turn into anything else. We're not really worried about anything else. And the reason that you need to do anything about a simple cyst is this, where it actually bothers someone enough, came in and wanted to do something about it. She had an incidental finding of another cyst in the left breast that she hadn't noted herself, was asymptomatic, and that complicated cyst. So instead of just being filled with fluid, you see in this upper corner, a little bit of maybe some debris or something in there as well. Those, though, by and large, benign, but usually 6-month follow-up is recommended just to demonstrate stability.
Really get an ultrasound on the breast, breast, and then 26-year-old.
Not you. I'd already done her exam at this point on the other side and taken her history. There was nothing concerning in the other breast. Yep. So just did a targeted ultrasound in this side. Both in the left breast. Yep. And this other one says 12 o'clock, 9 o'clock, small breasts. They weren't that far apart, so incidentally did this one as well. Yeah. I have blissfully been unaware of it if she hadn't had pain at that site from the other cyst. So with her about what to do about this, I shared with her what I've just said, that you don't really have to do something about a simple cyst and even a complicated cyst unless it's bothering you. Some people with very small breasts can have a benign cyst that is sticking out of their breast and changing the shape and contour of their breast, change their bra fits. That's a reasonable reason to aspirate it. And in her case, she was having significant discomfort from it, so we aspirated in the office, took 12 cc's of fluid, and she asked me if it was the grossest thing that I had ever seen. Which, not quite. Next case, I saw a 42-year-old woman who, she came to me actually kind of after the fact because the timing of when visit happened. But her history was that of having a tender rope, and these were words, extend down kind of from her axilla on this left side, and then wrapping around under her nipple. And her description was so good, and whoever she sent from accurately recorded it in the note that as I was reading that, I thought, aha, I think I know what that is, which we'll get to in a second. But after talking with her, I said, her breast at this point looks pretty normal, and so I pulled up a picture to show her, asked her if that's in fact what it looked like, and she said, yes, oh my gosh, absolutely, that's exactly what my breast looked like, and it had, a cord right here, it felt like a rope, it was really tender, and over time it's just gotten better. Mondor's disease, it was immediately crossed my mind as I was reading this, and then even more after meeting her. So it's a rare cause of pain, really superficial thrombophlebitis of superficial veins in the breast. A clot and some inflammation of these veins, and it can have really concerning appearance. I mean, this picture, when you saw that, you would think, oh, wow, she's got breast cancer. And of course, that's what we have to rule out before we can be reassured in saying, yep, this is probably just Mondor's disease. Actually, what she described is the textbook presentation for Mondor's disease, which is rare. So I was kind of excited to see something that was so classic for it. These things, breast surgery, though really we don't see it often after breast surgery. Trauma, shaving, you could think of as trauma to the axilla, tight clothing, and very, very rarely in association with breast cancer. That's very rare. Just having Mondor's disease doesn't increase future risk of breast cancer. So once it's on, you don't necessarily need to change their management strategy going forward. And it's usually self-limiting. I saw her, I think she was about 2 months in, and it was already almost completely resolved. It's really just reassurance after appropriate imaging to allow you to give that reassurance and say, yes, there is nothing concerning on the breast. Warm, wet compresses, NSAIDs, basically treatment for superficial thrombophlebitis that you would do around the body. Any questions so far? That one is, and mod is really quite weird here, so you may not see it, but you've heard about it again. So this next gal, 45 years old, a lady, came in and she had some left nipple discharge, multiple ducts, brown, bloody in color, and it was spontaneous. It was just coming out of the ducts without any prompting, and she herself had noted some palpable nodularity versus masses, kind of lower quadrants of the breast. With them then. She went imaging, mammogram, and ultrasound, saw multiple dilated ducts. Not surprising in the case of somebody who's having nipple discharge, but saw some central solid components, the little masses within the ducts of the breast. She had several of them actually, ranging in size from 0.4 centimeters and then up to 1 centimeter, and that actually correlated with the main area that she was feeling as palpable mass. So you can kind of up here, I think best seen in this right upper quadrant picture, breast, right upper quadrant, the right upper corner of the screen. You can actually see a little mass there marked off by the radiologist within the duct. So we have corneal biopsies of 2 of the dominant nodules, and they both came back basically as papillomas. One said intraductal papilloma, one said a sclerosing papillary lesion, would really treat them much the same. So a papilloma, breast cancer, it's that can grow inside the duct of the breast and a really common cause of nipple discharge. Now, we doubt them for several reasons. One, it's the common cause of discharge. Patients come in with nipple discharge. By removing it, then you can stop the nipple discharge. But also because when we papilloma, that is biopsy-proven papilloma preoperatively. So, and excise that area, so we do a surgical excisional biopsy of the area, there's a 5-10% rate of finding something more, like a papillary carcinoma or ductal carcinoma in situ that was in the vicinity, and that the corneal biopsy maybe wasn't a full representation of everything that was going on at that time. Another reason to excise them. And lots of people may have papillomas in their breast and never know about it. Factors that increase that chance of upgrade, so we call this the occurrence finding a malignancy on the surgical excision after not seeing cancer on the core biopsy, an upgrade. So many patients tell me it's not an upgrade, that's an downgrade. And you change what you call it. If you have a palpable papilloma, that's higher likelihood for finding than cancer on surgical excision. If the size is greater than or equal to 1 centimeter, if it's symptomatic, nipple discharge, or if it's associated with atypia. So if on that pathology we saw papilloma with atypia, that definitely has to come out. In this particular case, one papillomas was palpable, size, symptomatic with nipple discharge, so recommended excision of these 2 sites. The most common cause of serous or bloody nipple discharge. The most common cause of serous or bloody nipple discharge, is not actually cancer. So we radioseed localized excision of both sites through a periolar incision, little incision along the edge of the areola, which ends in very nicely with time, and you'll just have a little fine line along the edge there. And final pathology showed just papillomas, no atypia. And once we have this final pathology report, we've actually excised them. If there's no atypia, it doesn't contribute to the overall risk of breast cancer. So even there's that risk of upgrade or basically sampling error of finding something more in the surgical excision, once we've ruled that out, we're at the same risk that they were before. Result for her. Take a little drink. Quest so far. From here in the distant land. No. Okay.
Would you say that you are imaging 80% of people whom you see? I mean, I guess you're obviously people who have already maybe seen a primary care doctor, but
Yeah.
in general, I mean, it sounded like your concern goes up when you have more localized breast pain, so you can point to it. But I mean, if you look, I presume most doctors are going to image for the complaint of breast pain.
Yeah. If it's cyclic and it occurs with their menstrual cycle, it's bilateral, diffuse, taking up the whole breast, image for that, if that's the only symptom they're having in their breast. Even if it's random in its timing, it's intermittent, associated with any particular trigger, but again, it's bilateral, diffuse, whole breast, not so worried. If you get into having unilateral pain, and even more so if it's in a very focal location, absolutely. Yep.
Just getting at, are we over imaging for this? But I guess, that makes sense, but keeping it to unilateral in general.
Yeah. And for the most part, anything with a fluctuating course, so coming and going, is not so concerning for cancer. You never know. But in general, that's very reassuring. Next, we have a 66-year-old female with right nipple discharge, unilateral. It's clear in color, coming out of a single duct, spontaneous, so it comes out all on its own, not with nipple stimulation. Concerning exam, no other breast symptoms. She doesn't have breast pain. Diagram, which was completely unremarkable, and the ultrasound, which just showed some dilated ducts, maybe duct ectasia, which is a dilation of the ducts, maybe a little thickening, little debris in the duct. Is indeterminate, essentially. Specific target that was identifiable to say, that's what's causing your nipple discharge. And this is the case most of the time. So when we're seeing patients for nipple discharge, we really have to set them up. That may take multiple different imaging studies before we come to an answer. And we may not come to the answer. Sometimes, even if you've done all the imaging studies that are available out there, they're still having spontaneous nipple discharge from a that's clear or bloody, and we can't just ignore that. So then we have to do a subareolar excision and take out essentially a disc of tissue. So the nipple, if we've got nothing else to do more targeted incision on by imaging. So actually went on to have a ductogram. And ductograms are done really variably depending on institution. Some institutions pretty much don't do them, haven't found them very helpful in the past. It just so happens that a couple of our breast radiologists are really good at them, that they can actually be helpful sometimes. So first we had a ductogram on this right breast. They successfully cannulated that little teeny duct that was having discharge because they put a little tube into that to inject contrast into the duct itself. Usually where surgical loops to actually be able to see this nipple duct opening or doing that. And then they did the contrast and mammogram to see what's happening within the duct. And first had a very distinct point at which the contrast stopped. And it's a little hard to see, but there's a little filling defect within the duct. So, maybe a papilloma, certainly a picture for a papilloma with the discharge and then this little round filling defect within the duct. Other things on the differential, ductal carcinoma in situ, can't rule it out until you've ruled it out. Just some debris in the duct, which can actually cause nipple discharge itself. And then we took this and looked back at her previous ultrasound, because what I want to know is, can you localize that for me before I go to the operating room so I can take out a sample of tissue just from that site and really minimize how much tissue we have to take out to get a definitive answer? Or can you do a needle biopsy, target area? So when they looked back and compared this to the ultrasound, they thought that, okay, now having seen this, if we look really carefully in that area by ultrasound, there's a little something there and we could target that, which is what happened. So she had a core needle biopsy, and that's all she's indeterminate. So we saw dense fibrous breast tissue with fibrocystic changes. And I say, great, but it's not enough of an explanation necessarily for this nipple discharge. It's not quite concordant. And I talked with the patient. She still had nipple discharge. It didn't stop. If the discharge stopped entirely, you could think maybe about just re-imaging her in a couple months. We sampled the duct in question because we have now disrupted it, caused the nipple discharge. Is that enough? So talked about various options, and we decided that, you know, this isn't a satisfactory conclusion to the story, and we really need more information. So we've done the biopsy. We now had a little biopsy clip, metal clip on the site, which even if it maybe wasn't exactly what we wanted pathology-wise in order to provide an answer, close enough to the area that now they can put a radioactive seed to the biopsy clip and I can go and take out just that area. So her kid's actually coming up, I think, this week. So we'll see what the final answer is on that. Pathology would be a nice conclusion to that story. Benign, but a good explanation for her nipple discharge. This is a patient who is 33. She had nipple discharge. Hers is now bilateral, so already I'm less excited about any breast-driven process causing this, any pathologic process. Coming from multiple ducts, it's dark green and multicolored, some more creamy, has no bloody. The story, it's hard to tell if it's spontaneous or not because she is very fixated on this and she's constantly checking her nipples to see if she has nipple discharge, which means she does have nipple discharge because she's stimulating them all the time and essentially squeezing it out. So it's really hard to tell. She's as well, kind of intermittent, diffuse breast, still breast, kind of comes and goes, random patterns, so not really concerning to me. She is a heavy smoker. She uses marijuana as well, which can actually contribute to nipple discharge, both of those. She's already had quite a bit of workup before I get to meet her. She's had a mammogram that was unremarkable. Ultrasound of both breasts has some benign-looking cysts. Evidence of pregnancy. Because it seems to be more of a potential systemic problem. She's had a TSH that was normal. Prolactin was a hair above the upper limits of normal, and she's had an MRI of the brain, which is normal. Some of this was driven by her as well. She's aimed for a definitive answer. Her nipple discharge could potentially cause, just what we know so far, could potentially be caused by a couple different benign things. Yes, they've been caused by something systemic, like hypothyroidism, ruled out with the TSH, prolactinoma, though unlikely with this presentation because it wasn't milk discharge. It's this green, thick, almost can be kind of sticky sometimes and multicolored discharge. It can give you this multicolored discharge, and that's a process of kind of, there's a question of cause and effect, but you end up with thick discharge from the nipple, and it's almost clogging the ducts. So ducts get kind of dilated, irritated. You can even have sloughing of the lining of the ducts, and it's an ongoing process. Not common in smokers. So she's certainly a reason potentially for that. marijuana on top of it. Fibrocystic change also can lead to some bilateral, multicolor or green, gray kind of discharge. And either one of those are benign. Nothing necessarily needs to be done about it. Give a summary what I've said about those two. Oh, is that how I put for her? And for her, it was mostly reassurance. We talked about pain. If that's bothering her a lot, stop manipulating her nipples and just leave them alone. And if she ever develops palpable focal mass or an area of persistent localized pain, absolutely come back and we should evaluate that. When we think about the potential causes for nipple discharge overall, lectin seems the obvious one, and then you can have various physiologic causes for nipple discharge, not pathologic. Lectin levels, hypothyroid, various medications can have this as a side effect, and stimulation. And that can be from a variety of things, not just the woman herself check to see if she has discharge and thereby encouraging the nipples to have discharge, but certain clothing, if you have a poor fitting bra that's constantly rubbing on the nipple, that can actually promote nipple discharge as well. So a bunch of things. And then other causes, papilloma, ductictasia, and carcinoma in situ as well can cause nipple discharge. In all, characteristics that we would be concerned about on my right side, your left side of the screen, if it occurs spontaneously without any prompting, comes out of just one duct, unilateral, so coming from just one, but not both, and blue or cirrus, clear in color. If it comes only when you squeeze the nipple, not so coming. Some spontaneous discharge can be benign. Coming from multiple ducts, that's more reassuring, and definitely if it's bilateral, much more reassuring that it's not from a pathologic breast problem. Anyway. Talked about a lot, but again, we kind of set people up to expect that we might try a number of different modalities for getting to the bottom of this, and we end up needing all of them before we get a final answer. Mammogram, definitely if they're over 30, ultrasound, plus ductogram. Sometimes we might use MRI. All those vary significantly from practice to practice, are a little bit controversial in selected situations. Sometimes we might test it for blood. And then bottom, multi-duct discharge, especially from bilateral breast, thinking more about systemic causes. Pregnancy test, prolactin, TSH. Discharge, it can be frustrating. Problem to work through for sure, without a quick answer. Good to see them for it. So, long as you can have an infection in the breast. For this patient, a 30-year-old, 6 weeks postpartum, came in with a tender red lump, near no signs of infection. She's breastfeeding. Nope. What happened? There we go. So, put a picture of how it might look. Little red area of fluctuance. Postpartum mastitis. So it would mean it's not quite developed into an abscess yet, but just an infection in the breast tissue. Staph is by far the most common cause. Happens often in the first month and a half of breastfeeding or in weaning, kind of in those transition periods. Includes antibiotics, continue breastfeeding, so you're emptying the breast and you don't have milk building up in the breast. Ultrasound can be considered if it's persistent, not in a way to rule out abscess. If abscess does develop, then aspiration, needle aspiration can be considered. And then in rare cases, surgical drainage. So we ended up getting to the point of surgical drainage, and where's actually, so this 35-year-old female, postpartum, lactating, and sent to me by the lovely Julie back there, had some latching issues, cracked nipples, and developed a hard, painful red lump. Had an ultrasound that was consistent with abscess, and this aspirated, needle aspiration, started on antibiotics, and she's being aspirated multiple times, this collection, multiple different courses of antibiotics, and she was getting fed up. This is not actually her. I wish I had taken a picture of her breast, which was impressive, but this is an example of a really extensive abscess taking up the significant portion of the breast. And in our particular case, it really was kind of the entire medial left breast and extending into the superior breast. It was, she had reason to be really uncomfortable, yeah. And so she got set up with repeated aspirations, and she wasn't tolerating them well. Everyone, it was extremely painful because it was reaccumulating super quickly. So even if you saw every couple of days to re-aspirate this, it was already tense, really tender at the time. And this was with her data driving our antibiotic choices, so we knew we had her on appropriate antibiotics. So she decided that she really wanted to just have drainage and be done with it. That with its own big gut. Still currently lactating at the time. We made a big incision into the breast, not even big. There's a high chance of a milk fistula. So constantly draining milk out the incision to drain all the pus. Discussion with her about this, that if we end up in that situation, some actually have to consider stopping breastfeeding on that side, which I hate to ever recommend, because in general, I want to be a supporter of breastfeeding, but it has to be kind of, you know, balancing the risks and benefits for her, and she's in constant pain, not to enjoy that time with her son anyway. So for a big decision, we did incision and drainage, which was quite extensive, like I said, extending up the entire medial side of the breast, and she had a spurt collection superiorly, so we had to open all of those up. And then what done actually to get a good balance between cosmesis and the appearance of the breast long term, but also having recurrent infection, is close part of the incision and leave a wick that slowly pulled over time, so like a little gauze packing ribbon. Allows it to continue draining and not reaccumulate. And her did have copious milky discharge from this opening as well, and decided to stop breastfeeding. In the last couple of weeks, come back to see me again and doing fantastic. And it's doing well. So baby Tom. In case we have a 50-year-old female with a tender, red, fluctuant lump near the area. She's a girl, gram in a couple of years, no previous, and she has a previous history of breast abscesses. When you get a breast abscess in the non-lactating woman, it's usually unilateral. Treatment is much the same: antibiotics, ultrasound, maybe aspiration. And if you can get an abscess to clear up with aspiration alone and not have to do incision and drainage, even though that is the, taught in surgical training, the definitive management for an abscess in the breast, it also means that you end up with an incision on the breast that maybe you could have gotten away with a couple aspirations and antibiotics. In this case, not lactating, at least you don't have the added concern of developing a milk fistula afterwards. That's a slightly lower threshold for incision and drainage. You did rule out malignancy, especially in an older woman, especially in somebody that hasn't had imaging in a couple of years. If it's a slightly different scenario and she just had her, screening mammogram 2 months ago, it looked totally fine, and now she has something that for purposes in clinic looks like and smells like an abscess, ahead and treat it and just re-image her afterwards. Recurrent areolar abscesses are much more common in smokers, and you can actually have kind of a chronic recurrent abscess, and may even develop a chronic fistula tract, draining either actually near the nipple. And I have a patient actually who is in that situation right now and still smoking. That patient is it? Yeah. You've gotten all my notes about our extensive discussion. She's lovely, but she's still smoking. Yeah. And in that case, for that, I'm recommending, and she's quit smoking anyway, and she's working on it. Not actively infected because she has a sinus tract that's keeping everything decompressed. She flushes the sinus tract daily with saline, which is work for her. So I'm going to sure to quit smoking, and then I'll be happy to take out the sinus tract and this kind of chronic run around her old abscess cavity. So we'll see. I am hopeful, but realistic. Let's see. Any questions right now? So I have an old female who some mass in her breast herself, left lateral breast. Thinks it's probably been present for a couple of years, but recently it's become tender and it's bothering her a little bit, so she wants to get it checked out. By exam, it's well circumscribed, it's mobile, moves easily, not fixed to the skin. Oh yeah, I've talked for a long time. Do you want to ask for questions? Yeah, I can speed it along. Moral of the story, by exam, felt very reassuring. Well circumscribed, mobile, not fixed to anything. Ultrasound agreed. It all looks probably a fibroadenoma by imaging. To find out, it's probably the same one she had imaged a couple years ago. Basic fibroadenoma that looks like fibroadenoma on imaging, feels like it on exam. You can follow up with a 6-month ultrasound, and this is just to demonstrate stability. Basically, we want to prove that, yes, it's fibroadenoma, it's staying put, it's not growing, making it suspicious for it actually being something else. They want a reassurance, corpsing, observation, or if they really can't stand being there, excision. Other reasons potentially for excision as well. Do this. So size is a relative indication for excision. 2.5, 3 centimeters. I'm much more easily convinced to take them out when they're size as opposed to somebody with a 1 centimeter asymptomatic fibroadenoma that just now they know about it, they can't get it out of their head. You do incision in your breast for that. Increasing in size, either by exam or on serial ultrasound, that's a reason to take it out. Pain, it can be painful, or cosmesis. Again, some people with small breasts can have a fibroadenoma that might not even be that big, but it sticks out of the breast. And that is a very reasonable reason to take it out. Another case I had, a 16 actually with a mass palpable right breast. No, that update up install right now, right? No. Okay. I just want to make sure we're not going to shut down. Make you aware of that. And hers was about 2.5 centimeters in size. I gained significant anxiety about this mass, and it was very easily palpable. I could kind of understand. But a serious conversation with her, because location, it was immediately below the edge of the areola. It could affect breastfeeding for her in the future if she wanted that, because inevitably any incision into the breast is going to disrupt some ducts. Somebody can come in through an inframammary incision or from the axilla. It depends on anatomy, and in her case, it was going to mean a lot of extra work and stretching of tissue and probably going through more tissue in the end to get at it from one of those approaches rather than a periareolar incision. So she opted to have it out. and pathology came back now, and she had had a core biopsy in advance, by the way, that said fibroadenoma. In the end, pathology said benign phalloides tumor, and measured 3.3 centimeters. And now we end up in a little bit of a discussion, because when we're taking out a fibroadenoma, we really just enucleate it. Take the mass itself, try not to take out any breast tissue. Fibroadenoma typically pushes the breast tissue out of the way, so when you take it out, it comes together and the breast looks fantastic. You want to take out a lot of extra tissue, especially if you've had a biopsy in advance saying it's benign. A tumor is a little different. It's a mass also that develops from the supporting structures of the breast, so not the ducts, not the lobules where breast cancer comes from, but everything else in the breast, the fibrous and supporting structures. And they can cause problems just by their sheer growth. They tend to recur and grow and grow and grow. So for her, going back and getting a wider margin around that area, which is kind of the classic standard management for a phalloides tumor, would mean significant deformity for her breast. So becoming more and more accepted, specifically for the benign phalloides tumor, which are the least aggressive phalloides tumors, to observe in cases like this. 16-year-old chances are still that it will not come back, and I go taking a big chunk out of her breast just to help reassure all, it's not going to. So she's going to come see me every couple of months for an ultrasound for a while, and we'll just make sure that it's coming back. First down, looks good. Question kind of leave there. There's so much more we could talk about. But I thought about it. It's like, oh my gosh, I didn't even talk about atypia. I need to add that. Super common topic.
Thank you so much.
You're welcome.
Great.
You're welcome. This is my last little something to keep an eye out. Staging is changing for breast cancer. So instead of just TNS, tumor, nodes, metastases, now the grade, the tumor markers like estrogen receptor, progesterone receptor, all of that, genomic tests like oncotypes are being added into the stage. So the stage you mean more because it takes all that into account, but it's getting super complicated. So in case you see anything about that in the future and are confused. I know, yes. Hi, nice to see you. Nice to see you. No, that's okay.
Come down here and then I had a patient. How's life?
It's good, yeah. I totally understand because I was just talking with Linda. And she was like, people will be filtering in. I'm like, it's fine. That's reality.
It is.
I get it. It's like the patients where you're coming in half an hour late. So sorry,
And
you're like,
see it now, so it's weird not seeing it like in the middle of the night running around.
Yes, yeah. It's nicer in the middle of the day.
Yeah.
Yeah.
Got new hardware.
Yes.
Good. When's that happening?
Well, hopefully this fall. We're working on finding a venue.